So this is Clinical Conversations, COVID-19, the sleep medicine perspective. I am Mohammad Adeel Rishi, and this is a product of AASM Sleep and Public Safety Committee, of which I am a member. We are honored to have Dr. Morgenthaler with us today. He's my teacher and now my colleague. He's the professor of medicine at the Mayo Clinic in Rochester. He's the co-director of Center of Sleep Medicine at the Mayo Clinic and vice chair of Mayo Clinic Quality and Affordability. He also happens to be the past president of AASM. Hi, Dr. Morgenthaler.
Hey, Dr. Rishi, thank you so much for having me. And I also just want to tell you, thank you for doing this series. I think this series by the American Academy of Sleep Medicine is just super. And I know from other colleagues across the country who've been viewing it that they find it very helpful. So thank you for the investment of time and energy on both yourself and those who you're working with at the Academy for putting this together.
Thank you for the kind words. So without further ado, let's just get into it. So let's start by asking, given your special location in Rochester, Minnesota, and the unique nature of the practice at the Mayo Clinic in Rochester, what considerations went into making your policy in response to the pandemic conditions that now exist across the United States of America?
Yeah, so thank you for the question. So Mayo Clinic in Rochester is a bit of an unusual entity because we're a very large international referral center placed in a very rural area. We do serve a large regional population, so people from a 5-county area or so, from 3 states, southern Minnesota and northern Iowa, and also parts of Wisconsin. And so we have that regional practice to consider, and then we have a strong national referral practice and some international patients as well. So as the COVID pandemic conditions became apparent, we really had to consider several things simultaneously. And it won't surprise you to know that first and foremost consideration was safety. We know we need to keep our patients safe, and we know that coworker safety is of absolute importance always. And so our efforts really focused in 2 directions. First, we had to consider how would we deal with new patient evaluations or follow-up or established care visits that were already on our calendars and upcoming. Many of those people were already registered and had traveled from out of town to see us. So Mayo Clinic in general began screening practices in an attempt to identify patients who were at increased risk for having COVID so that we could try to keep interactions as safe as possible. In those early stages, this involved members of our desk staff eliciting a travel history to identify patients who might have recently traveled from areas of high prevalence of COVID, and to identify patients with symptoms that might be suffering from COVID, such as cough or fever or dyspnea. Depending on the outcome of that screening, then the patient and the providers were asked to don appropriate protective gear for face-to-face interactions. And as I'm sure happened in most places, over the subsequent weeks or so, the travel history became a little less pertinent, and we knew that more and more patients were asymptomatic, and so the screening operations actually moved to, who would they allow in the building and visitor restrictions. But really, right away, it was apparent to me that we had to significantly ramp up our virtual care capabilities. It was clear that we would need to move from face-to-face interactions to virtual interactions to keep both patients and coworkers safe. And so it was really important to me to arrange things so that all of our coworkers and team members could conduct most of their care from home. So to really do that, I'd say in the first week of all this, I assembled a few of our key clinic leaders to begin to plan how would we move clinical operations into a virtual sleep medicine center, anticipating that we probably need to make that change within a week or so. The second issue that we considered simultaneously was, what are we going to do about testing? So under what conditions would it be safe to continue in-lab attended polysomnography, and what would our capacity be for home sleep testing? So I took that same leadership team and then augmented it by some of our lead technologists and IT specialists to really start working out those problems as well. We anticipated that we would need some capacity for testing not only local patients, but also national patients. And so pretty much right from the beginning, we assumed that we wouldn't be able to interact much with our international patients, at least in the near term. For those international patients who already were in Rochester and sort of in progress, we just made all of their visits a priority right away in that first week to try to complete their itinerary so they would be ready to return home. So that's, I guess, those were our early considerations.
Yeah, I mean, I think you kind of touched on kind of the basic things that probably were going in the minds of many of the sleep providers across the country as we were starting to see more and more patients. So let's move on to the next question. How did your practice adapt to the increasing demand of telemedicine? So what did you actually do? I know you touched on that a little bit in your previous answer, but what did we actually do to address those things? And then how did you notify patients to be set up for these telemedicine visits?
Sure. Well, fortunately, we've actually been equipped and using video visits and telephone visits for over a year and a half, maybe even 2.5 years. And although the volumes were quite low in the past, already last summer, our group, we had a sort of a strategic summit end of this last summer. And interestingly enough, one of the things we'd identified as a key strategy to be able to connect with patients better was increasing our video visit volumes. And we identified this as one of our key priorities. And that's certainly consistent with the strategic priorities at Mayo Clinic, one of which is to provide diagnosis and care for common and complex problems as close to home as possible, preferably in-home. So we've been envisioning for some time that a lot of our sleep practice could be performed using virtual care and in-home testing or monitoring. And we have some research projects going on to try to augment those capabilities. So really, for the past 2 years or more, we have been encouraging all of our patients to enroll on the Mayo Clinic portal and using the Mayo Clinic app. That means that it allows excellent two-way communication between our patients and us all the time. So they have full access to all of our records, full access to all of our laboratory tests all the time. And we think that that's so important to patient trust and patient care. So really, the majority of our patients, when COVID, moved in, already had online access to the tools necessary for video visits, because our video visits actually take place through the Mayo Clinic portal. On our end, all of our exam rooms in the Center for Sleep Medicine already had video capabilities. So the COVID pandemic, in an unanticipated way, really has accelerated the work that we already intended to do. One extension that I don't think any of us anticipated, though, was the need to be able to conduct video visits to the patient's homes from our homes, because one of the things that went into place pretty quickly at Mayo Clinic was our senior leaders saying, get out of the clinic, figure out how to take care of patients from home. And so fortunately, I have some really tech-savvy colleagues, and over about 1 or 2 weekends, we were able to work out all of the kinks so that at this point, I've been seeing patients from my home today, and actually most days this week we've been seeing more than 40 to 50 patient appointments from our homes to their homes. So Mayo Clinic as an organization, to adapt to this home-to-home business, had to make some adjustments. They had to increase their internet bandwidth. They doubled their VPN capacity. As an organization, they've made a lot of other tools available for virtual operations like Skype for Business, Global Crossing, different telephonic tools. And of course, we can all resort to old-fashioned email. Now, in the sleep center per se, there's 23 sleep medicine specialists at Mayo Clinic in Rochester, and we have 3 nurse practitioners and 1 physician assistant. And just to keep things fluid and stay connected, we all agreed it would be fine to share each other's cell phone numbers. So particularly in the early week or so, if we needed to talk with one another to figure out something or answer a question, we just called each other.
Okay. Yeah. Thank you for that elaboration, Dr. Morgenthaler. What operational changes did you make in the outpatient clinic and for the in-lab and home-based sleep testing?
So, as the COVID prevalence and risk increased, which happened rather rapidly, I'm sure most people felt that, Mayo Clinic made a decision to, most immediately we had to take care of like 2 weeks worth of appointments so that we had maneuvering room. And so we were all told to review our appointments for the upcoming 2 weeks and sort them into urgent, semi-urgent, or elective categories. And roughly the definite, I don't have them in front of me, but roughly urgent meant, you have to do it face-to-face to preserve life or limb, and we're just going to make it happen. Semi-urgent meant, gee, there's a serious, significant risk of serious deterioration of health within the next 1 to 2 weeks if some key interventions don't take place. And elective meant, well, we could actually defer that to sometime in the future, maybe when COVID risk was not a limitation. Of course, this was early on. We really didn't have a good sense for what the doubling time and the magnitude of this was going to be. So that bought us about 2 weeks of breathing room. During that first week and a half or so, as I had mentioned, in the sleep medicine center, we were really ramping up for significant capacity for virtual care and virtual testing. So pretty much right away, we started adding patients back to our calendar as virtual visits. Now, in order to get that to happen, our appointment office needed to contact patients and determine whether they were willing, make sure that they had the necessary equipment, or whether they preferred a telephone visit. And so there was a lot of personal, phone calls and contacts made by our appointment office with patients. We also had to look at internal consults, those that were being sent to us from colleagues within the Mayo Clinic. And so we reviewed those and we made a decision about whether we could handle those using an e-consult. So an e-consult is basically a chart review without interacting with the patient. And then, can we make that of value and send back recommendations to colleagues? Or do we need to convert it to a video visit or a telephone visit or some sort? There was a second issue, and that is that we need to make sure that we emptied our sleep center of personnel so they weren't at increased risk from exposure amongst each other and from any remaining patients. So we moved ourselves into a different pattern of operations. And what we have right now is we have one physician who is called the physician of the week. And so they're there Monday through Friday during working hours, and they're the on-site person. They're there to handle any needed face-to-face visits. We've had maybe only 1 or 2 or 3 over the past several weeks, or maybe there's something that requires urgent attention, or maybe there's somebody who needs to be on site for a physical signature or something like that. So we have a doctor of the week, and we do it in week-long rotations so that we really save the doctors of the week from exposure. They're staying at home. And then we have another person who's identified as the doctor of the day, and that person really handles supervision of any supervision that's necessary for our nurse practitioners or PAs or any of our learners who are seeing patients virtually. And they also are responsive to external physician or provider phone calls in need of advice or information. And then other than that, each provider who is scheduled for clinic time is carrying a calendar of virtual visits, and they're performing these from their home. So that's sort of how we operationalized this. I wouldn't say it's set in stone by any means, but we're in now our 3rd week of this, and it's working okay. So that's kind of the clinic operations. Concurrent with the commencement of screening for COVID in the outpatient clinic, we pretty much immediately continued any positive airway pressure titration in the lab, because that's a higher aerosolization procedure, and we weren't really equipped to do those in our lab initially. As we began moving both the patients and the providers out of the sleep center, we knew that we had to ramp up our home sleep testing. Now, fortunately, some months previously, we'd actually worked out all the things necessary to begin a mail-out service of disposable home sleep apnea tests. And this was, pretty much perfect for the current situation where we needed testing of patients at home, and if we didn't need to, we didn't want to be handling equipment that was coming from them. But we have retained also the ability to provide some type 3 home sleep apnea tests for maybe patients who need testing, who are in atrial fibrillation, or who are taking an alpha blocker or a short-acting nitrate. And we even can do overnight oximetry on those rare cases where it's needed. But then we have some procedures that we put into place, and we kind of checked out with our infection prevention and control people to make sure that we're doing a safe cleaning process for each equipment before it's reused. So for the time being, we're not performing any in-lab polysomnography. If somebody needs a positive airway pressure titration, we have arrangements that we can admit them to a room in the hospital. And we've had all of our sleep technologists enroll for and complete N95 fit testing. So I think we can do that if we need to, but so far we've not had to actually do that. So those are sort of the scheduling operational changes. We do all of our clinical work in an Epic environment. Epic is our EHR, and as you probably might imagine, in order to keep all the work organized, there's like daily changes to workflows that involve Epic. And so what you see in Epic has been changing daily. It's been remarkable to me that we haven't had more errors in those regards, but our people have just been working around the clock to make everything work. And so, I would say one of the great challenges of this COVID epidemic is how do you lead well in a setting of uncertainty and great change? And at least for my part, I've been trying my best to work on clarity of communication with our coworkers, not only of how to do things and what are our current operational adjustments, but also just being sure that we all keep mindful of what are our goals, what's the vision here, and how do these pieces fit together. And then also just encouraging everyone to take good care of one another, because relationships are really, really important during these times. And I hope that that's working out. I think all this change, this is probably the most rapid change that most of us have had to experience in healthcare. To be honest, I think it's been a lot of fun to work with such an incredible group of colleagues and administrators. They've just been fantastic as they've responded to this. I've been very impressed with how they've worked together and learned new ways to serve patients. And I've been impressed with how kind they've been to one another. So I guess those are maybe those don't all belong to operational changes, but I probably said more than you wanted me to. That's where I put us on those things.
I think you make a great point about keeping that connection, although we can't be in person of each other, having that, at least having that virtual connection with our colleagues is so important in these testing times. So what sort of operational changes are you making to address additional patient calls and concerns?
Yeah, so all of our patient calls and concerns come in either electronically through through the Mayo portal or via telephone. And all of these are then routed to individuals who are really quite well equipped to respond. We have an outstanding group of nurses and administrative assistants who are sort of the first responders to these. We've as a group, we've worked to create clear expectations that those of us who are working at home, you are in fact working. You must be responsive to your pager and to your in-basket and to your email and so forth. And actually, everybody's just been very responsive to that mandate. Because a lot of these conversations and concerns with patients are really, from people who are frightened. They might have significant inconvenience or significant barriers to getting their care. So we've worked really hard to develop scripts that answer their questions in thoughtful and empathic ways, yet clear so that they can take action on them. And that way we're able to, speak into their knowledge deficits and hopefully speak into their emotional concerns. We get great help from that from our patient experience colleagues who have, helped us refine some of those messages so that they get across the right thoughts and emotions to the patients that we're serving. And I've been very impressed with the patients that I've been, talking with online and doing video visits. They're very appreciative of how Mayo has been able to adapt to these changes and serve them right in their homes.
I would echo your thoughts on that. I think patients have been, in general, very receptive to virtual visits and understanding of the limitations given the COVID pandemic. So one of the concerns that patients may have is in regards to the use of PAP and the risk of spread of virus. Do you have any particular recommendations that you are giving to your patients in this regard? And are you giving any particular recommendations for changing or replacing masks or filters?
Okay. So, of course, we do think that PAP use in an infected individual would increase the risk of spread to somebody else who's occupying that same space, because the use of the PAP has that high bias flow that's likely to sort of aerosolize any droplets that the person was breathing out. So in the first week or so where COVID was making its presence known in the United States, boy, we got a lot of calls about this. I'll bet you and the other listeners did as well. I actually picked up a thread on Twitter where a group of sleep medicine colleagues that I knew from across the country were working on this. And it was really kind of fun to see the work take place virtually to come together and develop some recommendations and critique one another. So I sort of took that discussion where it left off, and then I brought it to some of my colleagues, and we have some fairly standard recommendations. It's very dangerous to say your recommendations out loud these days because everything's changing so rapidly. So you're always afraid that you're going to be wrong. But in general, we're recommending that, if a patient is concerned that they might have coronavirus, either because they have a positive test or they've been exposed to someone with a positive test, or they have symptoms like cough or shortness of breath or fever, that they should go through a list of questions. The first one is, if at all possible, they should really separate themselves from others within their home. They could sleep in a separate room. They can use a separate bathroom. Really, these are recommendations that already are provided by the CDC, so I think those are pretty firm. Some patients, I don't think it's many, but some of them have an oral appliance in addition to CPAP, and if they do, we would recommend that they use it while they are still infected. If they don't, and if all they have is positive airway pressure, we would recommend that they use that if they have significant symptoms that would make them dangerous to operate in their home, or if they're having to operate in, some kind of equipment near their home. Hopefully they're confined to the home if they're symptomatic, or if they have significant cardiovascular risk factors, or if they have more severe sleep apnea. For milder cases, I suppose they could consider sleeping in a recliner, or if they have a positional component, maybe positional sleeping. Under any conditions, they should avoid things that would make their sleep apnea worse, like drinking alcohol and things. We haven't really given any specific recommendations for replacing masks or filters. I saw that on the AASM website, they posted the usual cleaning procedures for the devices, and we've sort of just echoed those recommendations to patients.
Thank you for that. For in-person interactions between providers, staff, and patients, how did you address concerns regarding safety? I think you alluded to some of this in your earlier answers, but maybe you can elaborate a little bit more on that.
Yeah, so one of the things we did when, like the first week we were still seeing face-to-face, and a little bit into the second week, and then after that we've really gone, 99% virtual. But when we were still working with the face-to-face, in addition to, screening patients and trying to just reduce the likelihood that we were having a face-to-face interaction with somebody who was symptomatic. In addition to that, we decided that if there was going to be an interaction with somebody who the screening questions showed them to be at higher risk, we had only one individual who was the individual who would interact with them for that day. So they were right away roomed, and that room then was treated as, sort of that was going to be the COVID room. And fortunately, we were not overwhelmed by numbers or anything like that. And that way, we only had one physician who could quickly review the donning of appropriate masks and gowns and gloves. And we would only have one room that could get re-cleaned and so forth. So we sort of elected to try to confine the risk in that way. With regard to staff interactions, pretty much right from the beginning, our mission was, let's get you home so you don't have to be exposed to people at work. For those people who are reporting to work, pretty early on, Mayo Clinic said you must take your temperature twice a day, and if you are symptomatic, you need to report it to occupational health. And we were very fortunate that across Mayo Clinic, very very early on, we had screening stations to where you could receive testing. So we've had pretty well worked out processes where we can detect early if a coworker is infected. If they are, they stay home. If they rule out and they have no symptoms, then we have a pretty minimal quarantine period before they can return back to work. So I think we've been doing a pretty good job of reducing staff to staff spread. Just in this past week, really sort of following along with the CDC, if today, if I were going in, I'm encouraged to wear a disposable cloth mask when I'm in near proximity to coworkers. Obviously, if we're going to be seeing a patient, then we have specific recommendations to that patient. Does that answer your question?
Yes, I think you did it very eloquently. Thank you for that. Anything else that you think that may be helpful to our colleagues across the country in this fast evolving and changing situation?
Yeah. I think it's just really, so first of all, wow, you know, I don't, it's a little bit amazing to think where we are today compared with just a few months ago. And, you know, in general, I mean, physicians in sleep medicine are innovative and energetic people. I've always been impressed by that. I think we actually are probably poised better than many practices in terms of our ability to change to virtual interactions with patient, to home monitoring, home testing. I think this will actually spur a lot of innovation and change in sleep medicine, which I think will be beneficial for the field as a whole. So I think in the meantime, I think the really important things are, number one, you know, we just need to take care of ourselves and our colleagues. You know, we need to be thoughtful of one another and not panic. You know, number two, I think for our patients, not only do we have to do what we can in terms of treating their illnesses, but I'm really pleased to see a lot of sleep specialists taking time to speak out publicly on social media or in their local news about how to help people sleep better, because, you know, sleep is so essential to the emotional health of our constituencies and the communities that we serve, but also to the physical resiliency. So I think we have something to contribute there by just giving good advice. And I think other than that, we need to continue to invest in the science of healthcare delivery for sleep medicine. I guess those are the things I'd say.
Thank you, Dr. Morgenthaler. Thank you for joining us and sharing your thoughts and perspective in these trying times. I am Muhammad Adeel Rishi, and this is Clinical Conversations COVID-19, the Sleep Medicine Perspective. If you want further information, you can go to the AASM website and go under the COVID-19 resources. Thank you.